Thanks, Mauro, very much for your kind introduction and invitation. And boy, I wish I was in Sao Paulo today. It's snowing in Canada. So today I've been asked to address the optimal use of integrase strand inhibitors in the clinic, focusing really on first-line therapy. These are my disclosures. I've worked with all of the pharmaceutical companies that deal with HIV products. So we really are what we would say in the integrase inhibitor era. I'm sure you're all aware of the ones that are currently on the market: raltegravir, elvitegravir, dolutegravir, and bictegravir. And these group of integrase inhibitors all act in the same way. They act as strand transfer inhibitors, interfering with the integration of the HIV virus into the genetic material of the T cell. Now, there have been a number of studies that have looked at the integrase inhibitors and compared them to the standards of the day, which have led to their recommendation as first-line therapy. So if we start at the bottom, these were the pivotal trials of raltegravir. In the START-MERC trial, we learned that it was non-inferior to efavirenz in terms of its efficacy, but better tolerated. Similar findings were in the ACTG study. The green box indicates all of those studies that have been done with dolutegravir, in which dolutegravir, the integrase inhibitor, was compared to efavirenz as a non-nucleoside, darunavir as a protease inhibitor, raltegravir as an alternative integrase inhibitor, and then studies in women, including the AREA study where it was compared to boosted atazanavir, and our more recent studies, the Gemini studies, looking at dolutegravir as a 2-drug regimen, and the advanced study in South Africa comparing it to efavirenz. And then the blue boxes are the newer studies with bictegravir, comparing that integrase inhibitor to dolutegravir with different backbone therapies. And I think you can see on the far right-hand side of this graph that in every circumstance, the integrase inhibitors were found to be either more favorable or non-inferior to the comparator. And in no case was there really any difference in terms of virologic outcomes, but it was really in terms of the overall tolerability of the drug. And that has also been shown in this graph, and I'm highlighting here the discontinuation rates of the integrase inhibitors because of adverse reactions in those various clinical trials. And you can see in each circumstance it's about 1 or 2%. So that is really one of the strengths of this class of drugs, is that they are so well tolerated that most patients are able to continue them for the long term. So as a consequence of those studies, all of our international guidelines, including the DHHS guideline, which is in the United States, the IAS USA panel, which is an international panel, the EACTS panel, which is largely Europe, and the WHO, which is the rest of the world, all recommend integrase inhibitors as being the preferred or highly recommended first-line strategy for patients on the basis of the combination of their efficacy and their tolerability. So if we look at integrase inhibitors as first-line therapy, we can ask ourselves, who is the candidate and how can they be delivered? So I think if we look at all those clinical trials on integrase inhibitors as first-line therapy, we've learned that they are effective in any gender, any age, any CD4 count, any viral load, late presenters, including those who are pregnant, and they've been found to be useful either orally as 3-drug or 2-drug combinations, and now injectable as part of a 2-drug combination. And they've also been looked at in terms of the rapid start. So what are the factors when you're going to consider? One, is the integrase inhibitor appropriate? But probably more importantly is, what is the partner drug that needs to be used with the integrase inhibitor as part of that first-line therapy? So obviously hepatitis B is a really important factor, because if an individual has co-infection with that virus, you want to make sure that the backbone therapy includes tenofovir and 3-TC. You need to consider whether or not the individual has either underlying or suspected resistance, either from transmitted resistance or from problems with adherence in the past. One needs to think about concomitant medications in terms of potential drug interactions. One needs to determine whether or not there's any particular food requirement which may inhibit an individual from taking a medication appropriately. We always need to think about adherence, but other key factors are tolerability, toxicity, cost, and access. So are integrase inhibitors the optimal choice for women? Well, we've learned from many studies, including the WAVE studies that compared Stribild to boosted atazanavir, that the Stribild did better for women. In the OLE study, which was then an extension of that trial, we learned that Stribild was also, and Genvoya were better than boosted atazanavir. And in the AREA trial, again, Triumec was found to be superior to boosted atazanavir. So again, the differences in these studies were largely related to differences in tolerability, in toxicity, and drug discontinuals, with all study arms having a very high level of virologic suppression. But the other good news is, for the few failures that did happen in these studies, there was no emergence of integrase inhibitor resistance. What about our older people? And many of us are experiencing that a large proportion of our newly diagnosed patients with HIV are more than 50 years of age. And so an advantage of the integrase inhibitor in our older population is there are fewer drug-drug interactions because of the metabolism of the drug. There are few metabolic issues, particularly lipids, which can become a problem as people age. And as a consequence of that, there may be lesser added comorbidity. Depression that may have occurred from the NNRTIs, cardiovascular disease that has been associated with the protease inhibitors or abacavir, bone disease that has been associated with tenofovir. And the other advantage of the integrase inhibitors is as you age, there is a natural deterioration in renal function, and these drugs are safe in that circumstance. So does real-world data support integrase inhibitors as first-line therapy, or is this just data from clinical trials? So I'll bring to your attention a couple of trials. First of all, this was published in AIDS just last month, and it's based upon the UK SHEIK study, in which there is almost 75,000 individuals, and they looked at the 15,000 individuals in this cohort that started first-line therapy between 2012 and 2017. There were some individuals who were excluded from their analysis, which ended up being close to 13,000 participants, and they were divided between about 6,000 who received an NNRTI, about 4,000 who received a PI, and another 3,000 who received an integrase inhibitor as first-line therapy. And what they were able to show, and this is the Kaplan-Meier plot, looking at the probability of virologic failure over time, starting with the integrase inhibitor. The top bar there is the NNRTIs, followed by the top line is the protease inhibitors, followed by the integrase inhibitors and the NNRTIs. So you can see in this circumstance, those individuals who started protease inhibitors were more likely to fail over time than either those starting the integrase inhibitors or the NNRTIs. And in fact, those individuals who had started on the NNRTIs did slightly better than those who had started integrase inhibitors. When they looked more closely to these, they looked at the different individuals in the class, and I will draw your attention to part C of this graph, which is looking at the different integrase inhibitors. And I think you can see that the graphs are superimposable and that there was not one integrase inhibitor that was associated with more virologic failure than the other. They also tried to address this and say, well, were a lot of these patients just blipping as opposed to true virologic failure? So you can see on the left-hand side of this graph, there are different definitions of virologic failure. And then you can look at the adjusted hazard ratio for failure, comparing the individuals receiving integrase to those receiving protease inhibitors. And again, you can see that those individuals receiving integrase inhibitors were less likely to have virologic failure by any definition within this cohort. So yes, those with integrase inhibitors did well in this cohort, did better than those on protease inhibitors, but perhaps not as good as those who received NNRTIs. And the authors argue in this paper that there was probably a bit of residual confounding, because in the real world, when we choose drugs for patients, there are other considerations that we bring into play, things like pregnancy, things like baseline resistance, things like adherence and the need for food or fluid, drug addiction, depression, which may have influenced the choice of agent in these circumstances. I'd also like to share with you, how then do you decide amongst the integrase inhibitors for first-line therapy? So there are three major drugs that are available at this point in time, and some of the decisions that we have to make are, is this drug available as a single tablet regimen, as many of our patients do want a single tablet. So bictegravir is co-formulated with TAF and FTC. Dolutegravir is co-formulated with abacavir and 3-TC. So if you want a single tablet regimen, those would be the drugs that you would choose. In contrast, raltegravir has to be 2 pills, and it's either twice a day in the previous formulation. There is a new formulation in which you can take 2 tablets, but it's 2 tablets once a day. So the number of tablets, whether or not you're going to take it co-formulated, may make a determination as to what choice is going to be for you. Again, the advantage of these drugs is that there's very, very few issues with drug interactions, so that usually does not influence your choices of one between the other. One of the issues that's come up recently, though, and will be a topic of conversation in this symposium, is what about the role of pregnancy? And I think many of you are aware of the fact that there was an initial signal around dolutegravir and the potential risk of neural tube defects in first trimester of pregnancy. That signal is now largely gone away, but we have had more experience with raltegravir, and many people, if they have a woman contemplating pregnancy, will use that drug because of the greater experience, whereas with bictegravir, we don't have any data at all about the safety in pregnancy. So are there situations where you may not use the integrase inhibitors and where you might decide that a PI is the best choice? And so many investigators are concerned that if you don't have resistance information, that it is much more difficult to become resistant to the boosted protease inhibitor, and may choose that as part of first-line therapy, and for similar reasons may choose a boosted PI if you think your patient is at risk for poor adherence. But there are challenges with the boosted PIs. There's lots of issues with drug-drug interactions. There are many problems with GI upset, hyperlipidemia, and potential cardiovascular risk. And at this point in time, we only have one boosted PI that becomes is available as a single tablet regimen. So what about NNRTIs? Is there a role for NNRTIs in first-line therapy today? And I think I showed you that data from the UK that demonstrated that, yes, maybe some patients will be fine on an NNRTI. Who might they be? So somebody in whom they've had problems with the integrase inhibitor, perhaps a woman who's contemplating pregnancy. And as you will learn later in this symposium, there has been now some concern about the relationship between integrase inhibitors and weight gain. And if you have a patient that's particularly concerned that, it may not be the best choice for them. What are the challenges with the NNRTIs? Well, in general, they are a lower barrier to resistance. So if you do have a patient in whom you're concerned about adherence, that could be a concern. As we all know, there were some neuropsychiatric side effects associated with efavirenz that may influence the choice of that drug. And because of the lower barrier to resistance, they may not be the best choice in those people with the highest viral loads at baseline, particularly when we're looking at the use of rilpivirine. And another challenge of that drug is the need for food in order to have the drug be absorbed. And then lastly of all is that the NNRTIs, because of their metabolism through cytochrome P450 and the fact that they're an inducer, again, there may be some issues with drug interactions. So another thing that's happened is there is a lot of recommendations now for rapid heart start. So the minute you meet a patient, the first time they come to their visit, is that the time that we should initiate antiretroviral therapy. And many of the trials have shown that if we use rapid heart, we're much more likely to get the patients into our practice and to maintain them in practice. And they may be more quickly suppressed in terms of the viral load, and consequently, there may be less risk of transmission to other patients. And so the NNRTIs, particularly bictegravir, co-formulated with TAF and FTC, is one of the recommendations for first-line therapy. Similarly, the use of dolutegravir with 2 nukes and the protease inhibitors have also been recommended as part of those rapid starts. In contrast, we do not recommend the NNRTI strategies as first-line therapy because of the high risk of transmitted resistance of drugs to that nature. And of course, we don't want to use abacavir as part of first-line therapy because we like to get that B5701 result back first to ensure that that drug will be safe. So the other situation is, what about a lead-in? So there are some situations with integrase inhibitors in which we have to start with one form of therapy and then switch. So for example, we now have the combination of dolutegravir and rilpivirine. It's known as Juluca in my country, and it has been shown to be a very effective therapy in switch. So that's not a combination that I would start a naive patient on, but rather it is a combination that you could switch to after you had patients suppressed on first-line therapy. We all know that we are now in the era where injectable antiretroviral drugs are being licensed for use, and the first one that has become available is long-acting cabotegravir together with rilpivirine, which has been studied in the FLAIR and ATLAS studies. And as we learn from those studies, there's usually an oral lead-in before we switch to the long-acting therapy to ensure that the patient is going to tolerate the drug before we have a long-acting injectable compound. And then lastly of all, there's been some question about the 2-drug combination that you're going to hear about later in this session of 3TC and dolutegravir. And although the Gemini studies have shown this to be a very effective strategy for starting patients with first-line therapy, the number of patients with high viral loads in that study is somewhat limited, and there are many individuals that would feel much more comfortable starting patients on a 3-drug therapy and then stepping down to the 2 drugs afterwards. So what are some of the gaps in our knowledge? Well, as I alluded to a minute ago, a lot of the studies that have been done in the integrase inhibitors have been much more recent. And we've had a change in the way we treat patients. We now treat them as soon as they present or shortly after they present. And so the CD4 counts of patients in clinical trials today are usually around 400 or 500 and even higher. Whereas in the past, in the era of the protease inhibitors, a lot of the baseline CD4 counts were 200 or 300. And so there are some people that still feel that we don't have all the knowledge that we need with the highest viral loads in the initiation of integrase inhibitors, although I think clinical practice will suggest to us that they work fine in those circumstances. You're going to learn a little bit more today about the safety in the first trimester. I think we can feel reassured that that signal with dolutegravir has decreased, but again, we don't have all the evidence that we need for some of these newer agents. You're going to learn a little bit more in this symposium today about the weight gain issues, and are they related to the integrase inhibitors or the backbone therapy, or is there some sort of interaction? We still need to learn more. There was a lot of concern when the integrase inhibitors were introduced because they drop viral loads so rapidly, whether or not that would lead to an increased risk of iris reaction. And although it has been described in some cases, there are clinical trials now with or without the use of integrase inhibitors, and it does not appear as if the risk of iris infection is increased. But I think the other gap that we don't have is, though the integrase inhibitors are much better tolerated, they have much better efficacy, we still don't have that piece of information. Do they really change mortality, or do they change the risk of comorbidity over the long term? So in conclusion, I want to share with you that integrase inhibitors are now recommended as first-line therapy for most newly diagnosed HIV infected persons. And these recommendations have been based largely on the combination of efficacy from the clinical trials, on the high tolerability, low rates of discontinuation of these drugs, and the low risk of drug-drug interactions. The choice of which one is often dependent upon the patient's wish for having a single tablet regimen, and usually on the basis of the backbone therapy with which you wish to combine the drug. So I thank you for your attention.